Welcome to the Critical Care Obstetrics podcast. My name is Julie Arafeh. I'm the Simulation Director at Clinical Concepts in Obstetrics, and today I'm here with my partners, Suzanne McMurtry Baird, Nursing Director, and Stephanie Martin, Medical Director. Today we're going to respond to your questions that we've gotten from you, our listeners. We put out a request for questions and we heard from so many of you. Thank you. Given the high number of questions, today's podcast is going to be limited to your questions about hemorrhage. In our upcoming podcast, we'll continue answering your other questions. So, first question, postpartum hemorrhage with normal vital signs. Do you give blood and follow the protocol or watch and monitor? What are your thoughts?
Well, I would first think and want to ask, what was your QBL? Second, were you doing QBL versus EBL? So important, again, distinction, since we sometimes over or underestimate with EBL, most of the time underestimate. So QBL would be very important in this situation, and staying and trying to do QBL in real time. Because the reality is sometimes if it's a lot of blood loss, you start seeing QBL done after the fact. And that's not as helpful at trying to figure out which stage you are in with your hemorrhage and where you need to manage. Secondly, again, I would want to know and make sure that you are verifying your vital signs. And, vital signs are vital. We always have to say that. And make sure that you're verifying those and doing some other assessments, components that may indicate, a further hemorrhage than what you either anticipated, or maybe they're doing hemodynamically well. What are your thoughts, Stephanie?
Yeah, so postpartum hemorrhage with normal vitals, this sounds like a stage 1 hemorrhage. So first thing, you're not going to be giving blood to somebody with normal vital signs in a hemorrhaging situation. Your patients will, if they're truly hemorrhaging enough to require blood, they're going to have abnormal vital signs in association with the QBL, a minimum threshold of blood loss that's going to cause abnormal vitals. Now, you don't have to have a minimum amount of blood loss that has to be lost in order to know to transfuse. Vital signs are going to be your biggest predictor of whether or not a patient needs a transfusion. But if they've truly got normal vital signs, then you don't need to be transfusing them in a bleeding situation. You need to prepare for it, but you don't need to give the blood with normal vitals. I would say that in this situation where you've got postpartum hemorrhage, they're bled more than 500, but their vitals are normal, this is where you're intervening and doing everything you can to identify the cause for the bleeding. Postpartum hemorrhage is not a diagnosis. The diagnosis is a laceration or uterine atony or whatever it is, and you're addressing it and correcting it so that you minimize the blood loss and ideally prevent the abnormal vital signs.
I wanted to also add some of the other thinking about that, and your response, Stephanie, is what other components of the assessment would you want to, look at? So not just verifying the vital signs, but what is her mean arterial pressure, which will tell you so much more than just an isolated systolic or diastolic pressure. So looking at her mean arterial pressure, is it greater than 65? So you want to maintain that mean arterial pressure greater than 65 millimeters of mercury. Also, other assessment things that I would want to look at what would be her pulse quality. You would still anticipate a patient without at least a 30 to 40% blood loss to have quality pulses. So at least a 1 to 2 to 3 plus, if not even 4 plus, depending upon where she was before. But you start getting 1 to 0 or a very faint pulse, then you've lost a lot more blood than you've even measured. So don't just look again at two components. Don't just look at blood pressure, because blood pressure is also a late sign. Look at your mean arterial pressure. Don't just look at your heart rate. Heart rate's going to go up as you lose more blood, obviously. but don't just look again at one isolated value. Do other assessment components to see what is time with that clinical picture too.
Yeah, and I want to go back to the question because the way they asked the question was very interesting to me. You've got a postpartum hemorrhage with normal vitals. Do we give blood and follow the postpartum hemorrhage protocol, or do we watch and monitor? Well, you're not going to transfuse with normal vitals, but you're going to follow the postpartum hemorrhage protocol and watch and monitor according to the postpartum hemorrhage protocol. And this is where your cognitive aids can be extremely helpful. Like you guys have heard me say before, I don't even go to the grocery store without a list because I will not remember everything I need to get. How can you be expected to remember everything in a high stakes situation like this where you're also doing multiple other tasks potentially? So, Julie, I know you have an opinion about this.
Mhm.
Yeah, I'm totally an advocate of checklists. There's absolutely no way you can say with 100% certainty that every single day that you take care of a patient, you're going to remember every single thing about even one of the most common emergencies, such as hemorrhage. So not only does it help you remember what to do, but it validates what you are doing. If there's some type of a disagreement, it validates what you're doing with the rest of the team. Why are you doing that? I'm following the checklist. For instance, we've got normal vital signs. Why are you doing this? I'm following the checklist. And the checklist is something that comes straight from your institution, from your hospital. So it is a great guide to follow and to justify your actions.
And your checklist should be based upon your protocol. So, again, you can't just cut and paste a protocol from somebody else and make it match the care that you're able to provide at your institution. So everybody's is going to look a little different. But I would say with 100% confidence, for those of you who do have a postpartum hemorrhage protocol, which I know all of you do not, because I've been in many hospitals that do not have a postpartum hemorrhage protocol. But for those of you who do, it is stage based. And so if you hit that over 500 mark, even if you hit over a liter of blood loss, what does it say? Most protocols are going to say continue to monitor closely and look at the vital signs. So it's not like you're just going ahead and ordering up blood at that point. No, you are watching the vital signs closely.
Yeah, your patient won't become hypotensive until she's lost at least 2 liters of blood for the average patient. So you can trust those vital signs. If she's hypotensive, she's lost at least 2 liters. You need to act. You need to do something about that and start replacing blood. But you can get without these cognitive aids like checklists and actual visual aids to go through your protocol and your algorithm, you can get lost in tasks and get focused on something. You can be doing all the right things to control the bleeding, giving medications, putting in a JADA device, uterine massage, etc., and not notice that your patient's that she's hypotensive because you forgot to take vital signs or you forgot to do QBL. So, you could technically be doing all the right things to stop the bleeding, but your patient can bleed to death in front of you if you aren't also doing the other things that are going to trigger give blood.
Yeah, one of the things that I thought about when I saw this question was we normally don't have a question like this posed to us, like, should we give blood when we have normal vital signs? Well, usual circumstance that we get questioned about is we have abnormal vital signs. We know she's lost a ton of blood. She's actually meeting, stage 3 or 4, and nobody wants to give her blood. That's the usual circumstance that leads to maternal morbidity and mortality. So I think that that's the key that we need to think about too. And how, if it was just the opposite of a question, then how would you manage that situation?
Yeah, I also liked this perspective because I love that they're like, we need to intervene. And that's a refreshing type of perspective.
Normally we don't see that too often. It's kind of like we want them to intervene and they're not,
Yeah, or you have more than one physician in the room with differing opinions about whether or not blood is actually necessary. One says yes, the other one says no, and they're about to come to blows over it. One of them is going to need a transfusion from some trauma going on, right?
Yeah.
I mean, we've all been in these tense situations. Well, I haven't personally been in them, but I've witnessed them. So, I mean, this is where your protocol takes that away. It's if this, then that. There's no discussion about, is her blood pressure low? Should we transfuse? It's her blood pressure is low, therefore we are transfusing.
Her heart rate is 150s and going up. Should we transfuse? The answer is yes. She needs blood. She needs blood. She's telling you, I need blood. Like, think about how her heart rate is working, laying there on the bed, beating at 150 times a minute. That's insanity to think that you're not going to get blood for a situation like that.
She's just anxious.
Yeah. Oh my Lord.
That's another podcast.
That's another.
Going on to the next question. How long should postpartum assessment of vital signs, fundal, and QBL be assessed?
Stephanie, I know you wanted to say it. You're about to blurt it out.
Until she goes home. No, I'm kidding. So you're going to be doing your assessment. I mean, I'm joking, but I'm not. You're going to be doing your assessment on this patient until she is stable and discharge prepared, whether that's transfer to another unit or transfer to home. But the frequency of the assessment and the type of assessment you're going to do is going to be based on what you're finding with your assessment. What are her vital signs? Is her fundus firm? Is it getting bigger? Is it getting smaller? What is the QBL? Like, what has transpired? So there's a lot of variables that go into this, but no one's ever been in trouble for assessing too much.
No. Yeah, and I think that a good point to make too with this question is, if you're moving a patient, let's say she meets criteria to move to a mother-baby unit, and she goes out there, this is the patient that you're wanting to check on sooner than later, okay? So you're doing your initial assessment as the mother-baby nurse, coming to the bedside, checking on this patient. If she has any abnormal vital signs, then you're going to want to assess again and not wait for that Q8 or Q4 or Q12 hour assessment that your guideline says that you must do. You're going to want to scooch that up more and maybe even do, more frequent vital signs. And just to be careful, just to make sure that this patient is still doing okay. So again, don't isolate and put in isolation these guidelines to where you think all patients therefore get a Q8 hour vital sign. That may not be the case. She may need vital signs every hour. It depends on what else you're seeing. I also want to say too, it depends on how much she lost too. Let's say she's just coming out from a 2-liter loss versus a patient who's lost, 1,001, and is declared both postpartum hemorrhages. That's a big difference.
Not only that, what's their hemoglobin level? A patient with a hemoglobin of 8 with stable vital signs is not a candidate for transfusion, but a little bit of blood loss is going to get her pretty anemic pretty quickly compared to somebody who's starting with a hemoglobin of 10.5.
Right.
So someone who you can bleed the same amount and go from 10.5 to 8.5, but if you're starting at 8 and you bleed the same amount, now you're 6.
Right.
So you might want to be, they're closer to the edge and at greater risk of complications. So your assessments may need to reflect that. And those vital sign orders are the minimum requirement, not what's indicated.
Minimum. Absolutely. And I think we've got to get out of that mindset. Oh, well, she's not due vital signs for another 8 hours. No. These patients are high risk now, and they need to be assessed more frequently and have, a lot of you have care partners or some, or if not, you still got to be able to do it as the RN to be able to assess.
So, kind of along the same lines, the next question: when can you stop weighing pads when they are 50 cc's or less within an hour?
Well, I think that again goes along with what's gone on before that. Okay. So again, there's a big difference between 2 liter of blood loss and, 1,001. So what's going on? What else is going on in your assessment? I don't know of any kind of randomized research looking at when you need to stop weighing, but I think it's just more of a common sense nursing judgment at that point. You may have a provider order that says that they want you to weigh QBL for a certain amount of time, but more likely than not, you don't. And you're going to have to use your nursing clinical judgment on that. Certainly, again, if she meets criteria to leave labor and delivery area and go to a mother baby unit, or if you work in an LDRP area, then you can say, hey, what do you think, guys? Ask your coworkers, say, this is what I have, this is what's going on, get another opinion. And you can make that judgment on when to stop. And certainly you would want to continue to measure QBL if she was, has a large amount of lochia, maybe even moderate, depending upon the clinical circumstance that the patient was in.
Yeah, and I want to say if you are going to call a provider with a report on blood loss, then you need to have weighed, unless it was not possible to weigh. It went into the toilet, whatever. But don't call me with fruit sizes or coin sizes. Don't tell me it was a clot the size of a lemon or quarter sized or whatever it may be. If you have a report to give about bleeding, it should be as objective as you're able to give. And so, there's no reason not to weigh it unless it's literally not accessible anymore. And that certainly happens, or it's not possible, but it's much more easy for us to react and respond appropriately when we're given objective information rather than subjective information.
Yeah, I think another clinical scenario that where it might be impossible besides the blood loss in the toilet would be if a patient comes in by EMS and it's on their materials and you don't have a dry weight, which often you won't. Then you're going to have to look at your other assessment parameters again to estimate blood loss. And there's one thing in our academy that I did the hemorrhage lectures, and it's in 2 parts. And one of the charts that I put in there is from the medical literature on estimating blood loss for an example like that. It's for the trauma patient. And so applying that to OB patients, you're going to start to see that patient become symptomatic when she's lost about 30 to 40% of her blood volume, which is quite a lot. Again, as Stephanie said earlier, about around 2 liters of blood loss. And you're going to start seeing that patient's heart rate go up and urine output come down and her pulse quality become weak and thready and those types of things, and her respiratory rate go up. So watching what goes with that, I think, will also clue your nursing judgment. And I would add one more point. At that point, I would love to see a note by the RN in the chart that says, utilizing nursing judgment, stopped weighing pads with patient's vital signs stable and quality, of her pulse or urine output and feels great, no shortness of breath, all of those things that I just talked about. I would love to see a note documented about why you used that judgment.
I'm glad you mentioned respiratory rate because respiratory rate is a key indicator for a lot of signs of early deterioration. We know that from the ICU literature. And obviously, it's not going to be picked up by your automatic devices. It has something that has to be counted. So you have to take time out of your busy list of tasks to get an accurate respiratory rate. And that's one thing that when I'm working with teams, I'm starting to assign that as a part of a task or a role that it's your responsibility to however many minutes it's decided by the team to count the respiratory rate and report it so that we're aware of that key vital sign and can keep a full view of the vital signs instead of just the ones that are being recorded automatically.
Amen, sister. You know, I'm all about that. I think we had a social media post one time that said, I think I put in search of the respiratory rate
Yeah.
because it's not there. And sometimes the temperature is not there either. So I just please.
Yeah. Well, those things are not things you can quickly look up and get. So there
Mhm.
has to be uh, some kind of an account made for how you're going to get those pieces of the assessment accomplished in a busy emergency situation. And that's where role delegation and clear assignment of tasks is really important. Okay, let's move on to this next question. And for those of you who, like me, are math challenged, you're going to love this question. How many points or percentage below the patient's baseline vital signs is normal? What if the hemoglobin is now 6, but they're symptomatic?
Okay, let's start with the first one there. How many points or percentage? So I'm going to say, what's 20% of 120 over 80? I don't know.
I don't know.
I don't know.
I have to get my calculator out.
I don't even know if a calculator would help me.
I don't either. I don't even. Oh, what's that formula for the calculator?
And I think what you guys are probably seeing a lot more is standardization of it's either this or that, and less in terms of a percent difference from baseline. Now, we'll address that more in a second, but I do want to acknowledge that there is something to be said for trending the patient's vital signs and understanding where she started and where she ends or where she's going. And trending over time is very, very important, especially like let's take a hemorrhage situation. You will see if you don't correct the bleeding and replace the lost blood, you will see the blood pressure go down and the pulse go up. So those trends are important. However, if the blood pressure is still normal, the blood pressure is still normal. If the pulse is still normal, the pulse is still normal. So this is where standardizing the definition of abnormal vital signs in pregnancy is so crucial. And that's where maternal early warning criteria come in. A blood pressure with a mean arterial pressure less than 65 is abnormal. A systolic greater than 160 is abnormal, etc. Suzanne, what are your thoughts?
Absolutely. I mean, I don't know of any of the early warning criteria for obstetrics that states any kind of percentage of decrease or increase as being abnormal. They're all absolute numbers. So simplify this task. I think that one thing that I would add is where I see this often is in anesthesiology orders when I'm looking at a chart and I see that they'll have an order of if the patient's blood pressure goes down a certain percentage, then give this medication. Again, I would simplify and go with the early warning criteria. The only way that would become helpful to know a certain percentage, and again, I don't find that clinically applicable too much, but in a hypertensive patient, let's say they got an epidural and it came down a certain percentage, but clinically, I don't feel like people are doing that at that point. But in this situation for the hemorrhage, it's an absolute number.
Yeah, I think some of this is kind of a holdover from the old definition of preeclampsia, which was a change in blood pressure from their baseline. And then the question became, what's their baseline? And even that has gone away years ago. It's either above 140 over 90 or it is not above 140 over 90. And that's really simplified things. So don't mistake trends, knowing the trends and the direction your patient is going with understanding what absolute abnormal is. And that's where maternal early warning criteria come in.
For those of you who are not familiar with mean arterial pressure or don't use it very often, it is the number in parentheses with your automatic blood pressure measurement that follows your blood pressure. So you do not have to do the calculation. It's a fairly easy calculation. I calculate it systolic plus 2 times the diastolic, that number divided by 3. That it's not a hard calculation to do, but you don't have time to pull your calculator out and do that in an emergency. So that number in parentheses by your systolic and diastolic is your mean arterial pressure.
Yeah, back in the olden days, we had to do the math, but thank goodness everything is done automatically now like that. So,
okay.
Yeah, and on the fetal heart rate tracing, when your vitals roll over onto the tracing, there's an M there, and it tells you your mean arterial pressure. It's even on your tracing. I've seen it on all the systems that I've looked at.
Yeah.
So the second part of that question, which was the hemoglobin's now 6, but they're symptomatic.
So I kind of wonder if this person maybe meant to say they're asymptomatic, but let me kind of take it both ways. So the way there is, to be clear, number one, there is no hemoglobin level where transfusion is mandatory. It's not. If you have a patient who's refusing blood, they can refuse blood even if I've seen the lowest hemoglobin I personally have seen is 1.5. And she did not get blood and she survived. Ooh. Jehovah's Witness patient, carefully counseled, etc. But there is a difference between acute and chronic, okay? Acute blood loss down to those very low levels has very high mortality rates when you get down into the 1 and 2. I mean, it's extremely morbid and very, very high risk. I'm not recommending that. I'm just telling you there is no magic number that you must transfuse or else. What I will say is that in the ICU setting, transfusing to an artificial target is gone. And really there's no, we're not trying to reach some magic number with the blood. If you have a patient who is severely anemic with a hemoglobin of 6 and has symptoms, she needs to be transfused, period. Hemoglobin of 6 with symptoms means transfusion.
And she's certainly not going home like that if she's symptomatic.
Correct. Now, sometimes those symptoms, the patient is refusing blood, for example. You can manage some of those symptoms by giving extra volume. Maybe she's lightheaded when she stands up, okay? So you can fill the tank a little bit more and give her large doses of IV iron and try and build up her hemoglobin level faster before she goes home. She needs to be asymptomatic if she's anemic before she goes home, in my opinion. Now, a hemoglobin of 6 that is chronic and asymptomatic, I've had patients come into the office, they tell me they crave ice. I checked their hemoglobin just a couple weeks ago. Hemoglobin was like 7.2. And she had iron deficiency anemia on top of an inherited anemia, thalassemia, that was undiagnosed, completely asymptomatic. I'm not going to transfuse her just to get her to a number. So are we in an acute hemorrhage situation or is this chronic? And then symptomatic or non-symptomatic. One more piece here is in an acute hemorrhage situation, your hemoglobin doesn't dictate your transfusions. Your vitals do.
Thank you.
Yeah.
Yeah. I mean, I saw that in a case the other day, and somebody was saying that she had a postpartum hemorrhage because she had dropped her hemoglobin. And that's not the way that we diagnose postpartum hemorrhage. So we're not, and in fact, the hemoglobin and the hematocrit take time to equilibrate. So we go over this again in the academy in a lot of detail because I think that's a common mistake made in hemorrhage that we'll go over in another podcast. But you don't determine hemorrhage based upon your hemoglobin and your hematocrit.
Yeah. So when someone's bleeding acutely, they're bleeding whole blood.
Right.
So the hemoglobin is going down at the same rate that all the other fluids are. So there's no decrease in the hemoglobin itself. That takes time. So your hemoglobin isn't going to decrease until the blood volume that's been lost is replaced with non-blood fluids. And then it dilutes out and the hemoglobin level drops as a concentration in the blood. So it becomes less concentrated in the blood, the red blood cells. That's what your hemoglobin is. So that's going to take hours to happen, not minutes or 30 or 1 hour. That takes a long time for that equilibration to happen. So the role of labs in a massive transfusion hemorrhage situation is to guide your clotting factor replacement, not your red cell product replacement.
That's a great point too, is the thing that you highlighted in there that I want to make sure that people understand is when you see this hemoglobin value, the first question I would ask, what is her volume status, intravascular volume status? Because if that's really diluted out with 4 or 5 liters of crystalloid, then it's not a true hemoglobin. So when was this drawn? And she may be asymptomatic with that hemoglobin because the hemoglobin is diluted out and it's not a true hemoglobin. So you need to wait and redraw and see later on after she has, resolved the over volume status, which may also cause that number to be falsely low. On the opposite spectrum, you could get a falsely high hemoglobin if she's under volume resuscitated. So again, another reason that we go into this, again, great detail in our academy about looking at hemoglobin and hematocrit values with a little cockeyed, just trying to figure out, okay, now I need to determine what her volume status is so I know what this truly means.
Vital signs are really the key way that we look at blood loss and volume. So I'm just going to throw a kicker in here. If it's important that everyone on the team knows if vasopressors have been started on the patient, because then that that kind of messes up the ability to see what's happening. Now, sometimes I think it's done because some physicians just want to get the view. Like, we want the blood pressure to be this, we want the heart rate to be this, without thinking about the physiologic mechanism behind why those vital signs are so abnormal. But key points here is if you are in a hemorrhage and someone is hanging vasopressors and hasn't told the team, that has to be communicated to everyone immediately,
Because
because
you got to get blood too.
that
There.
changes the entire way that you're going to determine administering blood or not administering blood. So I hope I didn't open a can of worms, but we have seen this happen so many times that I thought this is a good time to mention it.
I'm so glad you brought it up because I've actually been in that situation where I'm managing the hemorrhage. I'm in the surgery, doing the surgery. I look up at the monitor. I see normal blood pressure. I see pulse that is reasonably okay, 110s maybe, for example. And I think, oh, good, we're doing well here. But I don't know that she's on vasoactive medications and her blood pressure is artificially corrected. And that's not the right thing for the patient. That's where practicing this comes in. It's so, so important. You have to fill the tank, and you have to do that either before or during your vasoactive medication administration. Otherwise, you're just going to cut off circulation to vital organs. You're going to worsen your acidosis. You're going to worsen your perfusion. You're making a number better without making the clinical situation better.
That's treating a symptom and not understanding the cause or trying to figure out the pathophysiology associated with it. And you're dropping your cardiac output. So when you're hanging a vasopressor to manage shock, which is what this patient has, if she's consistently hypotensive with hemorrhage, she's in hemorrhagic shock without blood, then you haven't filled the tank. So if you are giving those vasopressors in a hemorrhage situation, you've got to fill the tank, and you fill the tank with blood.
Well, that kind of leads us to our final question on hemorrhage. And that question, we have some new anesthesia providers who state that our management of postpartum hemorrhage is outdated. While we do follow ACOG recommendations, there's always room for improvement, and we would like to do things better if we're in fact not practicing up to the standard of care.
We love this question too.
Love it.
And the reason we love it is because this is such a huge opportunity to bring in that professional group, and that is your anesthesiologist, which I think a lot of times they're not included in determining management protocols in OB emergencies, and they want to be. They are a vital part of your team, and they need to be included in that interprofessional planning of how you're going to manage this obstetric emergency. So I know Stephanie and Julie have many, many thoughts on this. And again, that we love this question because it really proposes an opportunity.
Well, I'll talk about the ACOG and the actual management issues, and I want to hear Julie give her thoughts on how to resolve this in a team performance kind of a way. But first of all, I love that there's questions here. It's like, are we doing the right thing? Do we need to be doing something? So first of all, if you're following ACOG recommendations, you're doing awesome. That is fantastic. Okay. That is a great way to approach the management of postpartum obstetric hemorrhage. So great. But there's always opportunity to do new things and evolve. So we thought of two scenarios in particular where anesthesiologists who maybe practice in other areas of the hospital where hemorrhage is occurring are maybe not seeing the same things happening in OB. And the two things that come to mind immediately are whole blood usage. So they might be seeing whole blood being given in a non-obstetric population and being like, why aren't we doing this here? And we agree. And the second is the use of thromboelastogram or tags in the management of DIC and guiding you in replacing blood products. So not everybody has access to, most people don't have access to whole blood, and many people may have access to tag in certain areas of the hospital, but not in OB, or maybe their anesthesia team in OB is not comfortable, or whatever it may be. I'm not saying that it's the right or wrong thing to do. I'm saying this is where you have to get together as a group and say, what can we do better? And let's practice it. So, Julie, what are your thoughts on that?
My thoughts are, first, I think it's fantastic if you can get the anesthesia team involved in any kind of discussion, whether that's simulation, tabletop simulation, whatever it is. And I can hear a lot of you out there saying, our anesthesiologists don't even want to come when we call them. We are not going to get them to come and help us do anything. So I have two basic strategies for you. You may not be able to get all of the anesthesiologists there, but if you get one, just one anesthesiologist who is interested in obstetrics, mine that resource, include that person, because they can be your first adopter, your early adopter, and maybe convince the rest of the anesthesiologists to get on board with the work that they're doing with your OB team. My second thought would be, and Stephanie and I saw this in one of the sims we went to, the anesthesiologist comes in and the anesthesiologist does not want to be there, is coming because I think was told they had to come. So the first question I asked the anesthesiologist is, what do you need to be successful in your tasks for the patient? And we got a complete different attitude, because now it was focused on what do they need? How can we make your job easier? What do you need? How far do you need the bed away from the head wall? What do you need set up? How much room do you need? What do you need brought into the room? So those types of things, I think, help engage the anesthesiologist. And then the other thing that I think is very important is talking about communication. And communication is key. What needs to be communicated? Who needs to hear what? And the most golden opportunity you'll have is when you have a full team that would respond to hemorrhage in your debriefing area after a simulation, and you can ask the obstetrician, what information do you need from the anesthesiologist? You can ask the anesthesiologist the same question, and then you can figure out what is the best way to facilitate communication between two very busy providers who need to talk to each other. So you can strategize as a team. You may want to have a nurse do a recap at that point where quickly the patient's status is reviewed. This is what we're currently doing. This is what we're going to do next, to bring everybody together and then solidify that plan of care so you don't have somebody off on one end doing something that the other end of the bed is not aware of.
I would agree. And I've seen that really play out in real time as well as in case review, where you are not seeing that communication. And I think that in this question, I love the way Julie presented that, this is an opportunity for you to, let's make your jobs easier, but also safer, but also, patient focused. What do you need to be able to be successful in your job and in this clinical scenario? And we've had wild success at engaging those providers, and it doesn't have to be an anesthesiologist. It may be obstetrics, it may be midwifery, it may be a staff nurse that doesn't want to be there for that training. But the minute that they are given the opportunity, I guess, to improve their patient care, I think that they become more interested. So I think that's a great point, Julie.
Yeah, and I think that these I don't know the context where these comments are being made, but to me, when I hear things like anesthesiologists saying that we're outdated, it's a symptom of perhaps frustration that if they're verbalizing on the unit or to nurses or to other physicians, it suggests that either they're outdated, but let's assume that they're not. Let's just assume that they're not just being included in the process or understanding how the protocols and the guidelines and all the things that are happening on the unit, how those decisions are being made. And it may be that they're being invited and they're not participating, but you don't really get to criticize if you're not going to help fix the problem. So I think there's a bigger issue here that needs to be kind of addressed. But in many, many places, in my experience, and I know you guys see this too, a lot of times protocols are written by a nurse in isolation. They might be distributed to a person or two, and then they're sent out on blast. Here's our new protocol. With very little interprofessional conversation about it, and certainly no practicing to see if it's even possible to accomplish what's being mandated in the protocol. And that can lead to these kind of interactions where it's like we're not doing what we're supposed to be doing, but people feel powerless to try and change it. I think it starts with simulation, and it starts with a view that we very strongly hold, that everything needs to be interprofessional. No one knows more than nurses don't know more than doctors, and doctors don't know more than nurses. They have different roles to play in these situations and different contributions to make, and all voices need to be heard.
Excellent points. That's the end of our questions. Final thoughts?
I can't wait to do the hypertension one.
Yeah, and just as a reminder, we have categorized these into certain things. So this was the questions we had gotten on hemorrhage. So we'll go into hypertension next, and I can't wait for that one too, because I love me some good severe preeclampsia or preeclampsia with severe features.
I just loved having these conversations with you guys. This is fun.
Yeah, we are so thrilled for the interest.
Yes, we really value your questions, and we thank you for listening. Don't forget to subscribe and leave us a review. You can learn more about the Critical Care Obstetrics Academy and our company at www.clinicalconceptsin.ob.com. You can also follow us on our Facebook page, Clinical Concepts in Obstetrics, on Twitter at OB Critical Care, and on Instagram at Critical Care OB. Email us or send us a direct message for suggestions on future podcasts.
This podcast was produced by Austin Baird. Are you looking to create a podcast? please email me at podcastnashville@gmail.com. That is podcastnashville@gmail.com.